Fokuskannya supaya
ya Bang.
kalau kau kenapa ada tuh? Di caranya itu udah mau masuk sini masuk
Ada orang lain gitu. Ada gitu.
juga masuk dari mana?
is
Aku udah
Good morning, everyone. Welcome to our online guest lecture. We will start in a few minutes. Please ensure your microphone is mute and feel free to turn on your camera. Thank you. Assalamualaikum warahmatullahi wabarakatuh. Good morning to all honorable lecturers, distinguished guests, and all students. Welcome to this special online session titled The Role of Medical Nutrition Therapy, or MNT in Type 2 Diabetes, Personalization and Evidence. My name is Ina Yunefi, and I am very pleased to be your master of ceremony for this event.
Gimana ganti namanya?
Before we begin, allow me to read today's agenda. First, opening. Second, welcoming speech. Third, main lecture. 5. Q&A session. Fifth, virtual certificate handover. 6. Documentation. And finally, closing. Let's open this lecture by reciting Bismillah together. For the comfort of this virtual meeting, please keep your microphone mute during the presentation. If you have questions, you may use the chat box or the raise hand feature during the Q&A session. To start this event, I would like to invite Vice Director 1 to deliver the opening speech. Mrs. Septianti, Escorp Nurse MPD, the floor is yours.
Okay, thank you, Ine. Can you hear my voice?
Yes, Mrs. The floor is yours.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone.
Morning.
Oh, Dr. Lee Yi. Good morning, Dr. Lee. The Honorable, our Director, the respected Head of Department, lecturer, and my dear students. It's a pleasure to welcome you all to today's guest lecture. On behalf of our institution, I would like to express my appreciation for this opportunity to us to learn together. Our topic today is diabetes mellitus that remains highly relevant as it continues to be one of the most significant global health challenges. So to addressing this issue, we need continuous research, innovation, collaboration within the health sector. We are truly honored to have Dr. Lee Yi with us today. Her expertise and experience in the field of diabetes mellitus will certainly provide valuable insight and enrich our academic perspective. To our students, my beloved students, I encourage you to participate actively. Use this opportunity to deepen your understanding about diabetes mellitus, ask thoughtful question, and broaden your professional outlook. And for Dr. Lee, thank you for sharing your time and knowledge with us. I wish everyone a meaningful and inspiring session. Good luck and thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Ms. Sati. And now we move to the main agenda. It is an honor to introduce speaker today, Dr. Li Yi. Thank you for being here, Madam. Thank you for the opening, everyone. Now, to get us through the rest of the discussion, I would like to hand over to our moderator for today, Salza Amelia. The floor is yours.
Good morning, everyone. Welcome to today's virtual guest lecture. My name is Salza Amelia, and I'm delighted to be your moderator for this session. Today, we are stepping outside our standard curriculum to explore the future of clinical nutrition. As we know, the landscape of diabetes management is shifting from one-size-fits-all to highly evidence-based, personalized care. To help us navigate this, we are joined by a truly distinguished expert in this field. Without further ado, please join me in giving a warm virtual welcome, perhaps with a clip emoji, to the Dr. Lee Yi.
Thank you, everyone. Can you hear me clearly?
Yes,
Yes,
Dr.
we
Lee.
can, Doctor.
Yes. Okay. Thank you very much. I will proceed to share my screen to share the slides with you. Can I check with you if you can see my slides in full screen?
Yes, we can see it clearly and in full screen, ma'am.
Thank you so much. Yeah, I think we should start. Yeah, good morning, everyone. Yeah, I am Lee Yi. I'm a dietitian and a senior lecturer at IMU University. Yeah, firstly, welcome everyone to the Zoom session for this guest lecture. Yeah, thank you for spending your time with me. Yeah, we'll be having 2 hours of lecture, yeah, including some Q&A at the end for this guest lecture today. Yeah, firstly, I would like to begin by expressing my sincere appreciation, yeah, to the directors of the Polytechnic Kesihatan Bengkulu for the invitation to speak today. Yeah, it is an honor to contribute to this academic session, and I'm very happy to see all the students here and to engage with you on the discussion on a very significant clinical topic and a topic of highly importance, yeah, in public health, as diabetes type 2, yeah, remains one of the most pressing non-communicable diseases globally, yeah, and also within our nation, yeah, within our region in Asia. The role of medical nutrition therapy, yeah, in the prevention of type 2 diabetes and in the management of type 2 diabetes is both fundamental and evolving, yeah, requiring continuous critical appraisal of evidence and clinical application. So I look forward to a constructive and intellectual engaging session with all of you. Yeah, if you have any questions, yeah, I can take your questions at the end of the session. Please do not hesitate to use the chat box. Yeah, and I will have some case studies to share with you for you to reflect and to brainstorm. Yeah, I've checked just now. We have first and second year and also some third year and final year students with us today. Right? So if I'm going too fast, yeah, our Miss Moderator, thank you. And also to our MC, just let me know if you need me to slow down. All right, all good?
Good.
All right. So let's look at today's learning outcomes, students. Yeah, we will look at the goals of MNT, medical nutrition therapy in type 2 diabetes. Yeah, we will look at the glycemic control, cardiometabolic health, weight management, and the long-term health management of diabetes. Yeah, so type 2 diabetes is a substantial global health concern, yeah, affecting 48% of the world's population by 2045. So it significantly impacts the individual's health and the economic burden of the patients, yeah, the health system of the country, and also the society. Yeah, the ever-increasing prevalence of type 2 diabetes, especially in developing countries, yeah, including Malaysia, Indonesia, yeah, most countries in Asia, has led to a surge and increase in healthcare costs, yeah, and a decline in productivity of the nation, right? Making it a serious challenge to the global public health scenario. Yeah, so the fundamental aspects of type 2 diabetes care would be the achievement of individualized glycemic control for your patients. Yeah, the minimalization of the adverse treatment effects, yeah, adverse chronic conditions of the type 2 diabetes, yeah, the implementation and comprehensive lifestyle and behavioral support. Yeah, I would not say only diet, yeah, because a lifestyle management and behavioral support coming from dietitians are also very important. Yeah, we'll look at the cardiovascular and kidney protection, yeah, and how we can provide a holistic care, yeah, a person-centered care tailored to the individual health needs and preferences. Yeah, so we will have a few parts of the lecture. Yeah, so we will have a short break in between. Yeah, so let's begin, yeah, with looking at the situation of type 2 diabetes within the global epidemiological context. Yeah, so according to the latest international estimates, yeah, approximately 589 million adults aged between 20 years old to 79 years old are currently living with diabetes worldwide. Yeah, this means that there is a global prevalence of roughly 1 in 9 adults living with diabetes. So the projections here indicate an upward trajectory because by 2050, yeah, the number of adults with diabetes is expected to reach 853 million. Yeah, and this is approximately 1 in 8 adults globally by 2050. Yeah, and all this projection reflects multiple drivers of this disease: population growth, yeah, aging demographics, yeah, urbanization of the environment and society, sedentary lifestyle, yeah, we used to be very active, yeah, in our occupation, in traveling, but now, yeah, even household chores are already, yeah, simplified, and we are becoming more sedentary, right? There's also a nutrition transition towards energy-dense dietary patterns. Okay, so importantly, yeah, we also see that 81% of the individuals, yeah, living in diabetes reside in low to middle income countries. Yeah, this has a significant implication on the healthcare infrastructure, on the burden of the country. Yeah, it will have significant implication on the access to medications, yeah, to nutrition care. Yeah, you have complication management and long-term disease burden. Yeah, so it is very important, yeah, that type 2 diabetes is not framed solely as a metabolic disorder, but rather as a major global non-communicable disease with a profound economic and societal consequence. And within this context, MNT or medical nutrition therapy here is not merely supportive care. Yeah, it is a central, cost-effective strategy for both prevention and long-term disease management of type 2 diabetes. Yeah, let us now contextualize type 2 DM within Indonesia. Yeah, this is results on the website of the Diabetes Atlas. Yeah, and Indonesia currently has the 5th highest number of adults aged 20 to 79, yeah, living with diabetes globally. And you can see the numbers on this screen. Yeah, and the prevalence in 2024, the age standardized prevalence was 11.3%. Right? And in absolute numbers, we can see that there's an increase, over time. From year 2000, approximately 5.7 million adults in Indonesia were living with diabetes. And by 2011, this number has rose to 7.3 million. Yeah, and recently in 2024, the estimates have increased dramatically to 20.4 million, right, from your National Health Survey. And the projections now, by 2050, it is estimated that the projection will reach 28.6 million, yeah, of the population. This represents not just an incremental growth, yeah, in the numbers. Yeah, you can see that the increase is about fourfold over 50 years. Yeah, 4 times increase over 50 years. Yeah, and Indonesia is also one of the countries and territory in the Western Pacific region, yeah, similar to Malaysia, right, which is recognized as a high burden region for diabetes. There are many drivers that contribute towards this epidemiological trend, yeah, rapid urbanization, nutrition transition towards more refined carbohydrates and ultra-processed foods. Yeah, you can see that previously there aren't a lot of eateries or shops, yeah, selling sugar sweetened beverages, yeah, or bubble tea. But now you can see that there are a lot of pop-up stores, yeah, that are going towards refined and ultra processed foods that are sold, yeah, for the normal population. Okay, there are also a lot of sedentary occupation. Yeah, people are spending a lot of time sitting, looking at their screens. Yeah, and the aging population structure, yeah, is also one of the contributors towards this increasing trend of type 2 diabetes. Yeah, and from a public health perspective, this magnitude of the disease has major implications, yeah, for cardiovascular disease burden, yeah, chronic kidney disease prevalence, yeah, increase in healthcare expenditure, and also decreased workforce productivity because of the impact of the disease. So now we examine from the Malaysian context where I am from, right? In 2024, the age standardized prevalence of diabetes, yeah, is high at 21.1% prevalence. Right? So this is considerably higher than the global average, yeah, and places Malaysia, yeah, at among the high burden countries for type 2 diabetes in the Western Pacific region, right? By 2050, it is projected that 7.5 million of the Malaysian population will be living with diabetes. Yeah, if you look at these absolute numbers, you can see that the increase is 12-fold, yeah, since the year 2000. Right, this is a very recent paper on the economic cost of type 2 diabetes in Indonesia. Yeah, this is from a systematic review where they compiled a few studies. Yeah, and they saw that the type 2 diabetes has imposed a growing economic burden in Indonesia, yeah, driving all these complications to rise, and this has also increased the prevalence of type 2 diabetes. So what are the complications? Nephropathy, yeah, impact on your kidney, cardiovascular disease, diabetic foot ulcers, yeah, are the largest contributors of the costs in managing type 2 diabetes. So in other words, complications in diabetes mellitus patients, yeah, lead to higher medical expenses, yeah, compared to those without complications. That is why it's important, yeah, for us to prevent the complications from happening too fast, yeah, in our patients, right? You will also see that the next most dominant component of the direct cause of type 2 diabetes would be hospitalization, use of medication, medical procedures, and also the lab tests that are performed, to diagnose and to follow up with the conditions of the diabetes patients. This is consistent with the findings from international countries as well. International studies that show that the components that cause the increasing medical costs would be the treatment cost, hospitalization, and all the related miscellaneous costs of the disease. And in patients with complications, more and more medications are needed, from time to time to manage both the diabetes and also the complications, right? I would also like to bring your attention to the indirect costs that may arise, from type 2 diabetes. This would include the loss of productivity, due from work absenteeism, if they are not well to work, the long-term caregiving by the family members, the costs and the implications, as well as the transportation costs for patients, especially those in remote areas who need to travel quite far to access the tertiary healthcare services in major cities. Next would be the Indonesia nutrition transition that is happening right now. Is undergoing a rapid process of nutrition transition. It is a shift of food consumption related to globalization, modernization, and urbanization, right? And this is with economic development. Of course, as a country develop, you will see a lot of economic development, but together with it, there are some potentially adverse impacts on diet and health, as well as the environment, if it is not taken care. And nutrition transition, right, is defined, as a process marked by the changes in the dietary patterns of the population, as a result of rapid economic development, right? You would see that with the food systems transformation, the increase of NCDs or chronic non-communicable diseases in low to middle income countries, would increase, right? Further, as part of the health impact of the nutrition transition, you would see a double burden of malnutrition. The double burden of malnutrition paradox is a condition where you see undernutrition and overweight population coexist within the same place. And the rising prevalence in overweight in many of the lower to middle income countries is also attributed to the easy access to affordable ultra processed food, and also sugar sweetened beverages, in tandem with reduced physical activity at work and at home, right? With the labor saving appliances at home, lower physical activity, all these have increased the prevalence of sedentary behavior. So experts who have written this paper, have perceived that the nutrition transition has also resulted in more eating out, in Indonesia, which resulted and promoted some obesity, through the unhealthy menu offerings from some eateries. The experts have also implied that sometimes some traditional diets may also be detrimental due to unhealthy cooking practices, especially deep frying, suggesting that the combination of higher consumption of fast food or unhealthy cooking practices as well may have worsened the cardiovascular disease risk factors and also type 2 diabetes risk factors in the population. So let us now revise some pathophysiology of diabetes mellitus before we go to the MNT, the medical nutrition therapy, right? You will see that the endocrine system here would be your body's chemical messenger system, the endocrine system here and the hormone that it produces, control a range of different processes in the body. And most importantly, it helps to maintain the homeostasis in the body. The hormones control a wide range of physiological processes, sleep, growth, metabolism, your immune system, right, reproduction, your mood, and your behaviors. So the endocrine system also helps in maintaining homeostasis, where there is a state of equilibrium, in the physiological processes by regulating your internal environment in your body, yeah, in response to the changes in the external environment. Yeah, and when this complex system is disrupted, yeah, including by changes associated with aging, yeah, disease may result. Yeah, and disturbances at any point of these complex processes, yeah, or the disturbances in the glands, yeah, in the endocrine system can result in diseases. Yeah, and endocrine disorders largely result from too much or too little hormone secretion. Yeah, and the hormonal imbalance here may be due to problems in the endocrine feedback system, genetic disorder, yeah, infection, injury, yeah, or any diseases to the glands, right? And aging also will lessen the endocrine system functioning, right? So one example here that is related to today's topic, yeah, and also to endocrine system would be insulin sensitivity that has been reduced in the body, which will increase the risk of diabetes, yeah, although these changes fluctuate significantly between individuals. Yeah, let's look into detail at the function of the pancreas here. Yeah, the pancreas is a long gland, yeah, looking quite flat, that is located behind your stomach. The pancreas serves two functions here. Yeah, we call it the exocrine and the endocrine roles, right? The exocrine roles of the pancreas would refer to the release of the digestive enzymes, yeah, including amylase and lipase that help to digest the food that you have eaten. Okay, there's also the endocrine role, yeah, of the pancreas, yeah, which refers to the production of hormones, yeah, called glucagon and also insulin that will regulate the blood sugar levels or blood glucose levels in your body, right? So this figure here shows a clear picture of glucose homeostasis, yeah, and the hormones as well as the organs that are involved in this process. Yeah, so when you eat a meal, your blood glucose will arise. Yeah, glucose is the preferred fuel, yeah, for all your body cells. And the digestive system will break down the carbohydrate containing foods, yeah, and fluids into glucose, where it is absorbed into the bloodstream. Yeah, and then the glucose will be taken up by the cell, yeah, from the bloodstream for fuel, to fuel your body, yeah, for you to conduct your daily activities, for your body to function. And then the receptors that are located in the pancreas will sense the blood glucose levels that have increased or decreased, yeah, depending on the conditions of your body. And then there are specialized cells called the islet cells, yeah, which will secrete glucagon, yeah, or insulin, yeah, to normalize your blood sugar level. Yeah, if your blood sugar level rises above the normal range, yeah, insulin is released. Yeah, insulin is released, yeah, which facilitates the uptake of the glucose into cells. However, yeah, when your blood sugar level drops below the normal levels, yeah, or when you're hungry, yeah, when there's hypoglycemia, glucagon will be released, yeah, and then the glucagon here will stimulate your liver cells, yeah, to release more glucose into the bloodstream. Yeah, this is some biochemical process, the pathophysiological process, yeah, related to the production of insulin and glucagon. So insulin here, when we are talking about the hormone insulin, yeah, if you look at the insulin structure here, it is composed of two polypeptide chains A and B, yeah, consisting of 51 amino acids that are arranged in two chains, yeah, that are linked by two disulfide bonds. Okay, and for the synthesis of insulin, proinsulin, yeah, would be the insulin precursor, yeah, that is transported in your body, and proinsulin is enzymatically broken down into the active insulin hormone and the connecting peptide, yeah, and we call it the C peptide. Both of these are secreted from the beta cells of the pancreas, yeah, upon stimulation from glucose, yeah, or other insulin secretagogues, that we use for stimulating insulin. Okay, while the C peptide has no known physiological function, it can be measured to provide an estimate of the insulin secretion by the body. Glucagon here, is a polypeptide hormone, secreted by the alpha cells of the pancreas, and you can see that there is a single polypeptide chain, and hypoglycemia, low blood sugar, is the physiologically most potent stimulus, and the best known action of glucagon is to stimulate glucose production in the liver, and thereby maintaining adequate plasma glucose concentration in your body. So remember the insulin and the glucagon, right? Insulin, it moves the glucose from blood into the cell, and you also have glucagon, which brings glucose out of the storage whenever necessary. And insulin is not the sole hormone player here with glucagon. There's also a hormone of what we call the epinephrine. It's a hormone that signals your liver cells to release glucose in fight or flight hormone. And in stress conditions, the epinephrine will ensure that all the body cells, will have energy fill in emergency for you to lift the situation, right? By releasing glucose from liver glycogen into the blood. So now into diabetes mellitus. Hyposecretion of insulin causes diabetes. So insulin is the peptide hormone. It helps to control blood glucose by telling your liver, your muscle, your fat cells, or enhance glucose uptake to reduce the blood glucose level in the body. So it facilitates the transport of glucose in the body, right? But in the absence of insulin, right, glucose in the blood is unable to enter the cells, resulting in hyperglycemia, where the glucose that would normally enter muscle and fat cells will remain in the blood, causing an increase in the blood glucose levels. A relative deficiency of insulin, or absence of insulin, will result in hyperglycemia. That's very important for you to remember that. So now comparing type 1 diabetes and type 2 diabetes, right? In type 1 diabetes, the pancreatic beta cells are destroyed by the immune cells, such as T cell, the macrophages, and the cytokines produced by the immune cells, resulting in an absolute deficiency in insulin, right? Leading to hyperglycemia. But in type 2 diabetes, right, you can see that the hyperglycemia, right, the pancreatic B cells are damaged by hyperglycemia, right, or hyperlipidemia, that's high lipid levels in the body, or by cytokines and amyloid accumulation in the body. So although the pancreatic beta cells still produce insulin, right, it's not absolute deficiency, there is still some amount. The insulin level here that is produced is insufficient to compensate for insulin resistance, resulting in a relative deficiency in insulin, leading to hyperglycemia. So now I would like to introduce you to HbA1c. This is a very important indicator that you often see, if you get the blood test results, when you see your clients or your patients. The HbA1c, or what we call the glycated hemoglobin, is formed when glucose in the bloodstream attaches itself to an end terminal of a valine of the beta chain of the hemoglobin inside your red blood cells. So this process is proportional to the concentration of glucose in the blood. So the higher the blood glucose level, the more hemoglobin will become glycated, right? You have higher HbA1c, right? The red blood cell have a average lifespan of 90 to 120 days, right? We are here now, and the HbA1c also reflect the average blood glucose concentration over the past 2 to 3 months, yeah, which is 90 to about 120 days. This is why HbA1c, yeah, is considered a very reliable marker of long-term glycemic control. Yeah, sometimes if your patient comes with fasting blood glucose levels, oh, it looks normal. But when you look at the HbA1c, it is not well controlled. Yeah, it indicates that HbA1c is a more reliable marker of your long-term glycemic control. Yeah, you can know if your patient have been controlling their blood glucose well. Have they been adopting your lifestyle? This is what you need to monitor and evaluate when you see your patients in the clinic, right? Importantly, right, HbA1c also correlates to the risk of microvascular complications of diabetes, retinopathy in the eyes or nephropathy in the kidney. So when we aim to reduce HbA1c with MNT, we are not just lowering the lab number, we are reducing long-term complication risk of diabetes. Okay. So let us look at the figure here, that is shown on the screen on the defects in the pancreas and in the target tissue for insulin action in type 2 diabetes, right? In non-diabetic individual, insulin will suppress hepatic glucose output. It will stimulate glucose uptake and utilize the glucose in the muscle and also in the adipose tissue, and therefore suppresses lipolysis in the adipose tissue. But when these tissues become resistant, from insulin due to type 2 diabetes mellitus, you will see that there is increases in the hepatic glucose production, right? And then lipolysis is also enhanced. You can also see that there is increased free fatty acids from the lipolysis process that will stimulate cellular uptake of free fatty acid and lipid oxidation, right? Moving towards the muscle, the increase in free fatty acids availability will also accelerate fat oxidation, which will result in the decrease insulin-mediated glucose uptake and utilization. We call this the ominous octet of the type 2 diabetes, right? If you go to the liver, the elevated free fatty acid also stimulate gluconeogenesis, and increase the hepatic glucose output. So when beta cell dysfunction in type 2 diabetes is present, the insulin resistance in the target tissues here, all will lead to hyperglycemia and to the further development of the type 2 diabetes. So what are the complications now? Moving on to the complications, acute and chronic complications that you might see in your patients. In acute complications, the blood glucose level become dangerously high, or sometimes dangerously low, resulting in death. There's also chronic complications of type 2 diabetes that affect all the different organs. We'll look at that in the next few slides. And all this will develop over time and with exposure over time to hyperglycemia. Therefore, a tight control of blood glucose will prevent or delay the chronic complications, right? And then if you see the acute complications, sometimes you can see there is high blood glucose, and sometimes there's also low blood glucose that happens to your patient. What are the signs of hypoglycemia or low blood glucose? Sweating. They will be sweating profusely, right? And then the vision become blurry, they become dizzy, or anxiety. They feel very hungry, irritable. And then there's also tachycardia. You feel that the heartbeat is very fast in the head. Sometimes they also feel headache and also have weakness and fatigue. These are all signs of hypoglycemia. If your the patients or your clients that you see in the clinic describe some of these symptoms to you, you can tell them that these are signs of hypoglycemia. And what are the acute management of hypoglycemia here? If your patient feel the symptoms, they can do some blood glucose, finger prick blood glucose monitoring. If the blood sugar goes very low, right, they can ingest, take a simple rapid fast acting carbohydrate, yeah, 15 grams, yeah, either from fruit juice or from a candy, right? And after the ingestion of the simple carbohydrate, they can continue monitoring their blood glucose and eat a usual meal at their scheduled time, yeah, due to hypoglycemia, yeah, your patients will need to take care, right? Otherwise, it may lead to some serious complications as well, right? Right, now going to the chronic complications of diabetes. Diabetes, yeah, can lead to severe life-threatening complications, yeah, but you can lower your risk, yeah, by making healthy lifestyle changes. The patient can make healthy lifestyle changes, knowing what are the warning signs, and of course, you have to advise them to attend the regular visits with their healthcare providers, right? You can see that the complications of diabetes is largely divided into the microvascular and macrovascular complications. Yeah, microvascular complications here will affect the small blood vessels. Yeah, firstly, look at the eyes. Yeah, there will be chronic hyperglycemia that will damage the vessels in the retina, therefore leading to retinopathy, yeah, cataracts, and sometimes potentially blindness in the patients. Yeah, this is a major complication of diabetes that is quite common, yeah, in the patients. Secondly, you go to the kidneys. Yeah, the high glucose level, high blood pressure will also damage the very small renal vessels, causing diabetic nephropathy. Yeah, there will also be the nerves, right? Neuropathy. Prolonged hyperglycemia in the body will damage the peripheral nerves, yeah, resulting in neuropathy, right? The patients will experience numbness, yeah, pain, and reduced sensation, especially in their feet, right? And also increasing the risk of gangrene and ulcers, yeah. If these are not taken care, yeah, it will become more chronic, yeah, more major, right? And then you can see there are also macrovascular complication involving the larger blood vessels. Yeah, in the brain, diabetes increases the risk of stroke and cognitive decline, right? In the heart, right? What happens? Insulin resistance, dyslipidemia, hypertension, right? The common conditions that happen together with diabetes, yeah, also increase the risk of coronary heart disease, right? In the extremities, yeah, you will see that the peripheral vascular diseases also reduces blood flow, yeah, to the limbs, resulting in poor wound healing and possible amputations. Yeah, I have seen patients in the clinics, yeah, in the hospital. They started with a toe amputation, and then they need to do a below ankle amputation, and then a below knee amputation. Yeah, all these can be due to poorly controlled diabetes, which has led to poor wound healing and also amputation. So the key message, yeah, from this would be persistent hyperglycemia, yeah, hypertension, dyslipidemia, yeah, the conditions all here will drive both microvascular and macrovascular damage. So this is why, yeah, MNT does not only target blood glucose, yeah, it also aims to improve your blood pressure, right? In the next discussion where we look at MNT, there's also advice, yeah, for your patient to look after their blood pressure, look after their blood lipid. How can you do that? Yeah, by reducing sodium, by changing your cooking methods, and you also have to take care of your body weight of the patient to prevent long-term complications of diabetes. Okay, so now we have looked at the traditional complications of diabetes previously, yeah, which is shown on the left side of the slide here, right? We have looked at the heart, yeah, peripheral neuropathy, retinopathy, yeah, and these are quite well researched, yeah, and is represented on the left-hand side of the diagram here, yeah. But I would like to bring your attention, yeah, to the right side of this diagram, yeah, with advances in the management of diabetes, yeah, the associations between DM, diabetes mellitus, and cancer, infections, yeah, functional and cognitive disability and liver diseases, as well as affective disorders like depression, are instead emerging now, yeah, as depicted on the right-hand side of this diagram. Yeah, this is not an exhaustive list of the complications, yeah, but there are studies that showed that cognitive and functional disability, yeah, non-alcoholic fatty liver disease, sleep apnea, depression are also quite common in people with diabetes. As these new complications of diabetes continue to emerge, yeah, the management of this disorder should be viewed holistically, yeah, and screening guidelines should also consider conditions such as cancer, liver disease, as well as prevention, yeah, which is why a healthcare team provider would be very important, yeah, to manage diabetes, right? We can see here some clinical practice guidelines on the management of type 2 diabetes. How well should glycemic control be? If you are looking at fasting blood glucose, it should be between 4.4 to 7.0. Yeah, if HbA1c, yeah, you can see that there is different cutoffs here. Yeah, usually they recommend for below 7 for most patients. Yeah, but if patients have been living many years with diabetes, yeah, they can recommend it to be 6.5 or lower. The HbA1c targets has been revised to the individual characteristics. Yeah, you can see that there are also targets for lipids, blood pressure, and also recommendations for exercise. Yeah, we'll be looking at this step by step, yeah, in the next few slides. Yeah, and if the patient is overweight or obese, yeah, we should aim for weight loss in over 6 months' time. Right, for the management of diabetes, education is effective, yeah, proven effective in improving clinical outcomes and quality of life of the patients, as well as their family members and carers should also be involved in the diabetes education for your patient. Yeah, so diabetes self-management education, self-care behaviors can include diet, healthy eating, yeah, advising them to be more active, teaching them how they can monitor their blood glucose level. Yeah, medications, yeah, the pharmacies can also come in to advise on the medication and how they can reduce their risk of complications. Yeah, food care, problem solving, and coping strategies for patients and their family members as well. Yeah, all these adaptation, including stress management, yeah, at the initial stage of diabetes diagnosis and the management of the complications are also very important. Yeah, therefore the team approach, patient-centered comprehensive care, yeah, would require a multidisciplinary team of healthcare providers. This include the diabetes educators, dietitians, nurses, the medical officers, yeah, pharmacists, physicians, endocrinologists, yeah, ophthalmologists if the diabetes retinopathy is involved, yeah, and also oral healthcare professional would be needed, yeah, to manage type 2 diabetes. As for dietitian, a referral to dietitian is required, yeah, to ensure that the patient receive dietary education. Yeah, dietitians' role are very important. We help the patients to develop eating plans, healthful eating plans, yeah, to help them manage their disease condition, yeah, that are appropriate to the individual needs and circumstances. Yeah, and in addition, dietitians will also help to identify or address any problems that are caused by eating problems, disordered meal patterns, for example, or if there are problems with the timing of the meals, eating disorders, and also other physiological and psychosocial problems. Yeah, all these issues may not be readily identified, right, by the doctors at the regular clinic visits. Yeah, so the role of dietitians, yeah, they can manage these eating problems as well, right? So the other team members here that are involved would also need to understand the principles of dietary advice, yeah, so that the whole team can assist in reinforcing the dietary recommendations. Yeah. Right. Now moving on to the medical nutrition therapy for type 2 diabetes. Yeah, it's important in preventing diabetes, managing existing diabetes, and delaying the complications. So proper diet is crucial at all the stages of managing diabetes, including those on medication. Yeah, MNT has a key role in diabetes management, yeah, including dietary interventions, yeah, being central to improving glycemic control, yeah, and overall metabolic health. There's growing evidence that suggests that dietary strategies will exert metabolic benefits, yeah, independent of weight reduction, right? And yeah, individualized dietary counseling by a dietitian is effective in lowering HbA1c by 2%, right? In 6 months' time. Yeah, it can also help the patient to reduce weight, cardiovascular disease risk, yeah, lower medication use, and improve their overall quality of life. So now, yeah, I would like you to reflect on these case studies. Yeah, reflect on the um, conditions here, and what are your MNT goals? Yeah, what would be your MNT goals? What would be your strategy for managing these patients? So look at case number 1, right? An executive, right, whose BMI is 29. Yeah, he's a male, 52-year-old with HbA1c of 8.5. Yeah, he eats rice, yeah, large portions, large servings 3 times a day, and frequently have a lot of sweet tea, right? And then there is also the urban young professional, yeah, 38-year-old female, yeah, whose BMI is 24, yeah, HbA1c 7.2, and eats outside 5 to 6 times a week due to the busy schedule. Of course, yeah, being very busy, young professional, yeah, she also takes a lot of sugary coffee beverages, yeah, that they can pick up along the way, right? So how would you manage this patient? Yeah, I want you to reflect on the case 1, 2, and 3 here. How would you manage? Yeah, and at the end, yeah, we will be looking at some points or discussion on how you can manage these patients, right? And then case number 3 is also quite interesting. Yeah, elderly patient, yeah, with early nephropathy, right? 67-year-old male, yeah, BMI is quite high, HbA1c 7.8, and then the GFR is 55 and has low appetite. But looking at the patient's age and low appetite, yeah, what would be your management for this patient? Yeah, think whether the patient needs some protein management. Is the patient at risk of sarcopenia? Would glycemic or would renal be your priority? What would be the modification in your diet for this patient? Right? So you can flip up your phone, take a photo of these case studies, yeah, if you want to think about it while we visit the next few slides, yeah, on MNT. Right, so this slide here would illustrate the important concept of type 2 diabetes being a progressive disease, yeah, that does not happen overnight. Yeah, let's look at pre-diabetes here. We begin with pre-diabetes, yeah, where the main function here, yeah, main issue here would be insulin resistance. Yeah, so at this stage, insulin is still being produced, but the body is not responding effectively to insulin. There is insulin resistance. This would be the most powerful window for lifestyle intervention. Yeah, very often if there is pre-diabetes, yeah, the patient would come to the dietitian, yeah, for lifestyle intervention. Yeah, either weight reduction, yeah, you improve their dietary patterns, you increase their physical activity, that will significantly delay or also even prevent the progression of type 2 of pre-diabetes to onset of diabetes, right? As the disease progresses, yeah, let's look at the early stages of diabetes where insulin resistance continue, yeah, and your insulin secretion begins to decline drastically. Yeah, here you can see that MNT remains foundational. Yeah, a lot of MNT or lifestyle intervention and medication may be already introduced by the doctor if needed. Yeah, and in the later stages here, Yeah, in the late stages, the beta cell function continues to decline further, yeah, resulting in insulin deficiency, right? So what would happen here, right? At this point, many patients already require combination therapy, including oral medication, yeah, and also sometimes insulin, yeah. But I want you to notice the key message in this arrow, yeah. Lifestyle and medical nutrition therapy remain continuous throughout all the process, all the stages. You will see MNT, yeah. Medication may increase over time, yeah, but the nutrition, the role of MNT does not disappear. And this highlight the importance of medical nutrition therapy. At the pre-diabetes age, yeah, the stage here, we would primarily focus on weight management, yeah, establishing a healthy eating patterns, changing their eating patterns, yeah, having some weight loss. This is the strongest prevention window, because even a 5 to 7% of weight loss, yeah, can significantly reduce the disease progression to type 2 diabetes. Yeah, in early type 2 diabetes, MNT, yeah, would become more structured. Yeah, the dietitians will focus on continuous weight management. Yeah, trying to reduce more weight, manage the carb intake, yeah, have cardioprotective nutrition and eating patterns. So at this stage, yeah, we would be working to reduce the blood glucose level, yeah, while also protecting long-term cardiovascular health. Yeah. At the third stage here, yeah, type 2 diabetes on oral anti-diabetic drug, yeah, OAD, when medications are introduced, yeah, nutrition does not become secondary. It still remain foundational, right? You need to also try to reduce weight, have heart healthy dietary patterns, yeah, maintain the carbohydrate management for carbohydrate distribution along the day, yeah, and effective MNT would reduce the increase in the medication needs. And if the patient is on insulin already, yeah, at later stages, yeah, sometimes insulin therapy is required. And at this point, MNT becomes even more precise. Yeah, you need to know how to manage carbohydrate management, how to calculate carbohydrate, how to match carbohydrate intake with insulin. Yeah, how to prevent hypoglycemia, and if hypoglycemia happens, how do you handle that? Yeah, and lastly, to maintain a cardioprotective eating patterns. Yeah, we'll discuss more on the MNT. Yeah, and now I think let's take a 5 minute break. Yeah, let me look at the time. We will reconvene at 11 a.m. Yeah, take an active break. Yeah, stretch yourself. Go for a short walk. Yeah, and we will reconvene at 11 a.m. Okay, for everyone? Yeah. Okay, I'll see you at 11 a.m. Right, students, I think we should continue with our lecture. It's 11 a.m. now. Yeah, I hope you have managed to have a short break. Yeah, stretch yourself and reduce your seating time, right? I'm a physical activity advocate as well. Yeah, so at the end of the lecture, we'll see, yeah, the importance of breaking prolonged seating time. Yeah, and how it can also help you prevent increases in the blood glucose level. Right? So moving on, yeah, while we talk about MNT for type 2 diabetes, yeah, we must be clear, right? The goals extend far beyond just lowering blood glucose, yeah, and the goals are all multidimensional, right? So MNT is a specific application of the nutrition care process in clinical settings, yeah, that we use to manage diseases, yeah, and the goal of MNT for type 2 diabetes, right, is to reduce HbA1c. We would like to improve clinical key outcomes, right? Reducing HbA1c, blood pressure, yeah, and cholesterol levels, and also achieve and maintain, yeah, body weight goals, right? So maintaining appropriate body weight, yeah, all these are not separate goals, yeah, all these are interconnected markers of cardiometabolic health. Yeah, so we need to improve the key clinical outcomes, yeah, of the body in the MNT, in managing the MNT. Secondly, we need to aim to promote healthful eating patterns. Yeah, you promote healthful eating patterns that are appropriate in portion sizes, limiting food choices only when it is supported by scientific evidence. So evidence-based information is very important, right? You focus on appropriate portion sizes, balancing dietary patterns, have sustainable food choices, yeah? So this is critical, yeah, because nutrition therapy should not be very restrictive, unnecessarily restrictive, yeah, because unnecessary restriction, yeah, will reduce the adherence to your dietary intervention, yeah. Thirdly, MNT must be individualized. Yeah, we tailor the nutrition care based on cultural food preferences, health literacy and numeracy, yeah, the willingness and the ability of the patient to make behavioral change, yeah, and their ability and willingness to adopt, yeah, the changes with the permission of their financial access and literacy. So in other words, the best diet here is the one that the patient can sustain, yeah, tailored to individuals, right? And finally, and this is also strongly emphasized, right, by the American Diabetes Association, the goal is to equip the individuals living with diabetes with practical tools, yeah, to manage their condition. Yeah, we do not focus narrowly on individual macronutrients or any single micronutrients. Yeah, neither do we demonize single food items. Yeah, instead we help these individuals to develop healthy eating patterns, yeah, that fit into their real lives. Because the long-term outcomes here are not determined by a perfect nutrient ratio, yeah, but by sustainable behavior that the patient can sustain, all the time. So the American Diabetes Association, or ADA here, yeah, have standards of care in diabetes, yeah, that include the current clinical practice recommendations, that is intended to provide components of diabetes care, yeah, with treatment goals and guidelines, and also the tools to evaluate the quality of care. Yeah, so ADA here have a grading system that is determined by the different studies that are conducted. So in the next few slides, you'll be seeing a lot of recommendations, and you'll be seeing small letters in red here, indicating A, B, C, or E. Yeah, A, it means that there is clear evidence from very well conducted randomized control trials, yeah, that supports the finding. Yeah, B, there are some limits, yeah, some identified flaw, yeah, but still supportive of the evidence. Yeah, C may be coming from some poorly controlled or uncontrolled studies, smaller studies, yeah, observational studies with some bias that was not controlled. But however, yeah, these evidences are still very important for you to know. right? And then there are also E here, which means these are from consensus from different experts in type 2 diabetes or from clinical experience while dealing with patients with diabetes. Yeah, so these are the grades of the evidence. If it's A, wow, it's very evidence-based already. Yeah, if you see B or E, okay, there are some lack in the control studies, right? And E is from expert consensus. Yeah, so let's look at all this, yeah, while we encourage the healthcare professionals, yeah, to shift from emphasizing macronutrients and micronutrients, yeah, and to focus on the whole diet, on focus on whole foods. Yeah, we will also encourage the team to think in terms of eating patterns, yeah, rather than on the specific nutrients or specific foods. Yeah, we also encourage nutrient-dense food choices, right? And all this is all integrative, yeah, along different multiple healthcare professionals and societies as well as dietary guidelines. So all in all, yeah, individuals, we consume food, yeah, not single nutrients, and nutrient recommendations would be applicable to what the patients actually will consume. Yeah, we will look at all these nutrition recommendations here, yeah, that is effective and beneficial to people with diabetes. Yeah, these are the latest recommendations, yeah, 2026 recommendations, updated 2026 by the ADA. Yeah, and you can see here that the nutrient recommendations here, yeah, start with the provision of individualized medical nutrition care, yeah, by referring people with pre-diabetes or diabetes to a registered dietitian nutritionist, preferably one who has experience in diabetes care, right? So when MNT is delivered by a dietitian, yeah, MNT, yeah, we know that it is associated with absolute decrease in A1C, yeah, this is already proven. Okay, when MNT is delivered by a dietitian, yeah, we help to manage the A1C decrease, yeah, absolute decrease by 0.3 to 2% among people living with type 2 diabetes. Yeah, and because diabetes is progressive, yeah, behavior modification alone may not be able to maintain, yeah, normal blood glucose levels over time. So even when pharmacotherapy is initiated, when the patient is on medication and also on insulin, MNT continues to be an important component in diabetes self-management. Yeah, and disease-specific MNT should be provided by the dietitians, yeah, who should assess and monitor the changes, yeah, in the patient's condition and also in the medication plan in relation to their nutrition care. Yeah, so all the healthcare team members should be empowered, yeah, to know that the nutrition advice have to be evidence-based and delivered by the dietitian. Yeah, they should know generally they should limit processed foods, yeah, foods high in added fat or added sugar or added salt, yeah, and when possible, advise the patient to choose whole food, right? So this recommendation here reiterate the importance of MNT delivery by dietitian. Yeah, when dealing with such condition, yeah, the patients that are living with diabetes would have additional health conditions as well sometimes. Yeah, hypertension, dyslipidemia, CKD, yeah, chronic kidney disease. Yeah, or if you get a younger patient, right, you need to take care of their growth, or the patients are also living with obesity. So all these would require the referral to the dietitians to initiate MNT. Okay, so the next few parts would be providing the overweight and obesity treatment plan, yeah, based on their nutrition, physical activity, and behavioral health status, yeah, for all the patients that are living with obesity or overweight, yeah, and 5 to 7% of weight loss should be aimed, yeah, for them to reduce or reset, right, their insulin insufficiency. Okay, so for 5.13 here, you can see that for diabetes prevention and management of people with pre-diabetes or diabetes, yeah, individualized meal plan should be recommended, yeah, that keep nutrient quality, total calories, and also metabolic goals in mind. Yeah, okay, and these red color alphabets are the level of the evidence that I've mentioned in the earlier slide, right? 5.14, eating patterns should emphasize key nutrition principles, yeah, including inclusion of non-starchy vegetables, whole fruits, legumes, lean proteins, whole grains, nuts and seeds, yeah, low-fat dairy or non-dairy alternatives, and minimize consumption of red meat, sugar-sweetened beverages, sweets, refined grains, processed and ultra-processed foods in people with pre-diabetes and diabetes. Yeah, and the level of evidence is also quite strong at B. Yeah, 5.15, reducing carbohydrate intake, yeah, for some adults with diabetes to improve glycemia. Yeah, an effective way to achieve or to reduce carbohydrate intake is by limiting consumption of processed foods. Yeah, don't worry, we'll be looking at each of this evidence, yeah, most of this evidence that is related to diet in detail, yeah, in the next few slides. Right. Next one, assess intake of supplement, yeah, as supplementation with micronutrients, yeah, or herbs and spices is not recommended for glycemic benefits. Yeah, you can assess their supplement intake. Yeah, and if it is not beneficial without evidence base, yeah, you do not recommend that. You do not need to recommend that unless there is a chronic insufficiency or deficiency, like vitamin D, for example, which can be quite common. Yeah, 5.17, you counsel against beta-carotene supplementation because there is evidence of harm, yeah, for certain individuals and have no health benefit. Right? 5.18, you advise the adults with diabetes and those at risk of diabetes who consume alcohol, yeah, to not exceed the recommended daily limits. And you add, for those who do not drink alcohol, yeah, they do not need to start drinking alcohol even in moderation. There's no need to start on alcohol. Yeah, but for those who are already consuming, yeah, advise them to follow the recommended daily limit. Yeah, you counsel people with diabetes about the signs, symptoms, and self-management of delayed hypoglycemia. Yeah, and the importance of monitoring glucose after taking alcohol to reduce hypoglycemia risk. Yeah, especially those who are on insulin. Okay. 5.20, you counsel people with diabetes to limit their sodium consumption to less than 2,300 mg per day, yeah, as clinically appropriate. And the best way to achieve this is to limit consumption of processed food, yeah, or food with high salt or added salt. Okay, next one, 5.21, you encourage people with diabetes, yeah, or those at risk of diabetes to consume water over other beverages. Yeah, take plain water. Yeah, don't take others sugar-sweetened beverages. Focus on air kosong, yeah, or plain water only without any added sugar. Right? You counsel people with diabetes or those at risk, yeah, that non-nutritive sweeteners, yeah, can be used in place of sugar sweetened product if consumed in moderation only, yeah, and for short term to reduce overall calorie and carbohydrate intake. If they really cannot live without taking a sugar sweetened beverages, then you can introduce a non-nutritive sweetener, yeah, but do not practice that for a long time. Right? Counsel and regularly monitor individuals pursuing intentional weight loss to ensure adequate nutritional intake, yeah, with particular attention to preventing protein insufficiency and micronutrient deficiency. Yeah, do not go on extreme diets to reduce the calorie intake. Yeah, monitor their protein intake and also micronutrient intake. Right? So emphasize minimally processed, nutrient-dense, high-fiber sources of carbohydrate, yeah, of at least 14 gram fiber for each 1,000 kilocalorie that is consumed. Yeah, carbohydrate food that has high fiber sources. Right? You advise people with diabetes or those at risk of diabetes to replace SSB, sugar-sweetened beverages, including any juices, with water. yeah, or a low calorie or no calorie beverage, and minimize food with added sugars in order to manage their glycemia and reduce risk of cardiometabolic diseases. Okay, the next ones, yeah, would be on the management of diabetes on some on diet, right? 5.26 here, yeah. You have to educate the individuals with diabetes, yeah, who are at risk of developing diabetic ketoacidosis. Yeah, you manage that and discourage a ketogenic eating pattern. Yeah, it's not recommended for patients with diabetes, right? Next, you provide education on the glycemic impact of carbohydrate, fat, and protein that are tailored to the individual's needs, yeah, tailored to their insulin plan and also the preferences of care, yeah, while if they are using some insulin dosages. You counsel people that are using insulin doses, yeah, to consider their insulin action time, the time that they are taking their carbohydrate intake to reduce the risk of hypoglycemia. Yeah, you also counsel the diabetes patient who are at risk, yeah, to incorporate more plant-based protein. Yeah, now there are some recommendations for plant-based protein. Of course, you can still take animal protein, yeah, but this is also a recommendation, yeah, as to increase the diversity of the eating pattern, yeah, and at the same time reduce the cardiovascular disease risk. Yeah. You counsel people with diabetes or those at risk, yeah, to consider eating plan that will have some elements of Mediterranean eating pattern, yeah, which is rich in fatty fish, yeah, nuts and seeds, and also to reduce risk of cardiovascular disease and improve glucose metabolism. So Mediterranean eating pattern, yeah, is recommended, can be recommended if they can take it. Yeah. Counsel people with diabetes or those at risk to limit foods that are high in saturated fat to reduce cardiovascular disease risk. So these are very common eating patterns, yeah, that you can recommend. Right now, we will go into detail of some of these important roles of dietitian where we can come in to manage their weight or have some individual lifestyle intervention. Yeah, so this is based on the recommendation on maintaining or reducing body weight. Yeah, aim for a 5 to 7% weight loss if your patient is overweight or obese. Yeah, so the management here is very important to support weight loss and also to improve A1C, yeah, improve the cardiovascular risk factors, improve their well-being. Yeah, they need to have individualized eating plan that will result in energy deficit, yeah, in combination with enhanced physical activity. So it's the same like you are managing an obese patient who would like to lose weight. Yeah, the eating pattern will have to be in energy deficiency. Remember the energy balance. Yeah, you need to have energy deficient to reduce weight. Yeah, in combination with physical activity programs. Yeah, so lifestyle intervention program should be intensive, and you should monitor your patient, have frequent follow-up, so that you know that their reductions are being monitored and it will improve the clinical indicators. So the behavioral modification goals that are involved, yeah, you address their physical activity, teach them how they can have some walks, yeah, how to increase the intensity, frequency of their physical activity, how they can restrict calorie, yeah, have these strategies and motivate your patients, yeah, and when they see that there are some weight that are being lost and improvement in their indicators, they will be more motivated to lose weight, yeah, and this would be beneficial. Yeah, sustained weight loss. Yeah, modest sustained weight loss will delay the progression of pre-diabetes to type 2 diabetes and would be beneficial for management of type 2 diabetes. Yeah, so this will also go back to the healthy eating concept. I will show you an example based on the Malaysian food pyramid. Yeah, there's no one food that will give all nutrients to our body. So the important healthy eating concept would be variety. You eat a variety of food from all the food groups to obtain the nutrients. Yeah. Your practice of your food intake will also need to be balanced. Yeah. Follow the guide and also in moderate portions. Yeah, this is one of the important reminders that you can provide to your patient before we go in depth into the carbohydrate calculation, right? Eating pattern, eating a variety of foods, not abstaining from any food groups would be the first important message, right? And then macronutrient distribution should be within the prescribed calorie. Yeah, you would calculate what is the requirement of your patient, and then you can make a meal plan, yeah, with the distribution within the prescribed calorie. There is no ideal percentage of calorie from carbohydrate, protein, or fat for people with diabetes. Yeah, therefore, the macronutrient distribution should be based on individualized assessment of your patient, based on their current eating patterns, yeah, based on their preferences, based on their metabolic goal, right? So members of the whole healthcare team monitoring the patient, yeah, should use evidence-based guidelines, yeah, like what that, like the recommendations that you are looking into now. These are all evidence-based. Yeah, you help people with diabetes make healthy food choices to meet their individualized needs and also improve their overall health, right? And ultimately, ongoing diabetes and nutrition education that is paired with support to change behavior would be recommended. And as dietitians, we also need to provide the meal plans, meet the recommendations is very, very important. Yeah, as we know, carbohydrate will affect the blood glucose level the most. Yeah, hence, you need to adhere to the macronutrient distribution, and the guidelines should be followed so that it will not promote hyperglycemia. You need to have high fiber, low GI carbohydrate options can be recommended. Yeah, for protein, it is essential, yeah, for you to have adequate protein intake to prevent, yeah, loss of muscle function, loss of muscle mass, right? All these should be inadequate. Yeah. The next one would be eating patterns. Yeah, research have confirmed that a variety of eating patterns can be acceptable, yeah, for diabetes management, like a Mediterranean style diet, right? A low-fat diet. Yeah, even patients who are vegetarian or practicing veganism can also continue with their eating pattern. Yeah, until evidence show that there are some eating patterns that could not be practice at all, then you should advise your patient against that. Yeah. Otherwise, you should follow the common core characteristics of healthful eating patterns. What are the common characteristics? Yeah, you include non-starchy vegetables. Yeah, green leafy vegetables, non-starchy vegetables, whole fruits. Yeah, not fruit juices, whole fruits. Yeah, legumes, right? Nuts, seeds, yeah, whole grains, and low-fat dairy product. Yeah, or if there is lactose intolerance, for example, yeah, the patients are adhering from dairy product, you can recommend some non-dairy replacement. And another important point is to minimize consumption of red meat, sugar-sweetened beverages, sweets, yeah, refined grains, and processed and ultra-processed food. Yeah, and the referral to dietitian and ongoing support from the dietitian is essential, yeah, for you to monitor the overall nutrition status of the persons living with diabetes. Yeah, the dietitian, you work with your patient, yeah, create a personalized meal plan, adhere to their lifestyle, right? Adhere to their schedule, work schedule, and their medication use, advise physical activity as well. Yeah, so having a shared decision making, discuss with your patient what you can do together. Yeah, this would be part of the nutrition care process for the patient. Right. Next, we will move into the carbohydrate management. Yeah, the component of the diet that has the greatest influence on your blood glucose would be carbohydrate. Yeah, and therefore carbohydrate management is crucial for you to achieve optimum HbA1c. Yeah, the monitoring of the carbohydrate intake would be a key strategy, yeah, to reach the HbA1c goals in your patients. Yeah, and the whole grain carbs, yeah, that contains fiber would be the recommended carbohydrate option. Okay, you can also consider reducing carbohydrate in some adults. Yeah, to improve glycemia. Yeah, an effective way to achieve this would be by limiting consumption of processed food. Take whole fruit, whole grains, carbohydrate. Yeah, rice, bread, cereals, and flour. Yeah, and carbohydrate may also come from starchy vegetables, fruits, milk and milk products. Yeah, reduce sugar, sweets, yeah, cakes, and also from whey. Right? And then the basic carbohydrate management. Yeah, this is very easy for you to remember. 3T. Yeah, the total amount of carbohydrate, the type of carbohydrate, and the timing of the carbohydrate intake. Yeah, carbohydrate need to be ingested in a consistent manner from a day-to-day basis. Yeah, you can also recommend high fiber, whole grain carbohydrate products. Yeah, and also low GI if the patient can afford. Yeah, and also the appropriate amount on how to calculate or exchange the carbohydrate items. Yeah, so healthcare professional, we should maintain consistent insight on the individual's carbohydrate intake. You need to recognize what are the types of carbohydrate, what is the portion or serving size of the carbohydrate. Sometimes very low carbohydrate eating plan may not be recommended for the diabetic populations who happen to be pregnant or lactating their children, or people with kidney disease or at risk of disordered eating. So your care should be individualized according to the conditions of your patient. Yeah, so this slide will show you how you can educate your patient to monitor the portion sizes of the carbohydrate foods that they are eating. Yeah, and all these food servings that you see on the screen now, contain 15 grams of carbohydrate, which is equal to 1 scoop of white rice. Here, 15 grams of carbohydrate. So if they want to exchange, if they need a carbohydrate exchange, you can tell them that they can get from some crackers or from bread. Okay, so for starch items, one exchange is equals to 15 grams of carbohydrate. So it's equals to 1 slice of bread, 1 rice, 1 scoop of white rice, or 1 cup of cooked rice porridge. Yeah, if you want to eat noodles, from rice-based noodles or flour-based noodles, it can be measured in cups. Yeah, and all these carbohydrate counting tools, you can educate your patient. Then all these portions can be handled by them, on their own. They can learn to manage their carbohydrate portions, within the recommended amounts. Okay, for fruits, half a guava or 1 medium apple, or 1 small banana, all these have 15 grams of carbohydrate. Teach them if they want to take fruits. If durian is in season or if rambutan is in season, sometimes your patients, especially when you see them binging on a lot of fruits, you should tell them that they should follow the carbohydrate portions, or otherwise there will be excessive carbohydrate intake or inconsistent carbohydrate intake as their nutrition problem. If you take a diet history, you may detect these problems among diabetic patients. Right? What about milk? 1 cup of milk or yogurt or milk powder, also provide you with carbohydrate, starchy vegetables, baked beans, potato, corn, all these will provide 15 grams of carbohydrate. Exchanges for fruits, more pictorial guide for you, of exchanges. And the next one, we would go to the eating plan or meal plan approaches or methods. Few studies have compared the different eating approaches for diabetes. Okay, there's also the plate method or the diabetes plate method. Can be a visual approach that can be commonly used to provide basic meal guidance for patients with type 2 diabetes. Even one randomized control trial have found that the plate method or carbohydrate counting were effective in helping achieve improved A1C. And then a plate method is very simple. You use a plate to visualize or to portion your food, where 1/2 of the plate can come from non-starchy vegetables. yeah, and 1/4 of the plate can come from protein, yeah, and 1/4 of the plate can come from carbohydrate items, preferably, yeah, whole grains and also items that are high in fiber, right? Carbohydrate counting, yeah, is a more advanced skill that you can help your patient to track their carbohydrate intake or the amount of carbohydrate that they have consumed at meals or as at snacks. Yeah, of course, this should be individualized according to the ability of your patient. Maybe some patient may be suited with this plate method, yeah, for them to portion their food, right? But some, yeah, if they have high literacy level, you can tell them how they can exchange their carbohydrate, yeah, and also count the carbohydrate using different methods. Yeah, you use the feed method or the hand jive method for them to estimate their carbohydrate intake. Yeah, one feast is equal to 2 exchanges of carbohydrates, for example. Yeah, the carbohydrate counting method, yeah, can be quite advanced, yeah, and should be individualized. Remember that, right? There are also newer technologies like smartphone apps, yeah, that you can take to use to take a photo of your carbohydrate intake and refer to an AI tool, yeah, to measure, right? Uh, However, yeah, more studies are required to know the preciseness of the carbohydrate intake. Right? So all these are estimations. There are also new technology like continuous glucose monitoring devices, yeah, that would allow the patient to have personalized nutrition approaches. Okay, so all in all, meal planning approaches should be customized to the individual patients according to their numeracy and food literacy level. Right. So people at risk of diabetes, yeah, or those living with diabetes should be encouraged to consume, yeah, a minimum of 14 grams of fiber per 1,000 of calories of their requirement, yeah, with at least half of the grain consumption being whole grains, yeah, and whole grain can be taken together with vegetables, yeah, or fruits to help to meet the fiber requirement, yeah, wholemeal bread, yeah, if they can afford brown rice, yeah, they can opt for brown rice or oats, for example. Yeah, and then they can also get the fruits and vegetables, yeah, from get some fiber intake from fruits and vegetables like guava, and also from other types of different fruit items. Yeah, sometimes we understand that fruits and vegetables or whole grains can be a challenge for your patients, yeah, even for Malaysians, yeah, and they can also be some cost issues. So it doesn't matter if your patient cannot afford brown rice, yeah, as long as they control the portions of the carbohydrates that they are eating, yeah, they know that they should be consistent intake of carbohydrate throughout the day, that is fine as well. Yeah, teach them that way. Yeah, you can incorporate vegetables and fruits. Yeah, encourage vegetables and fruit intake. Yeah, and the skill is also to suggest local fruits. Yeah, and affordable local fruits and vegetable options. So next one, the consumption of sugar sweetened beverages, yeah, is also strongly discouraged. Yeah, ask them to take plain water. Yeah, consumption of sweets and sugar sweetened beverage, yeah, can displace healthier, more nutrients than options. Yeah, and also increase the inflammation. Yeah, so opt for the plain water. All right. And then now, yeah, it's Ramadan month and there is also fasting ongoing. Yeah. This slide here will show you what are the primary forms of non-religious fasting and also religious fasting. So non-religious fasting can be intermittent fasting. Yeah, you can see sometimes your patient will ask you, can I follow intermittent fasting? Yeah, or time restricted fasting. These are some strategies, yeah, used to control weight and control glucose. Sometimes you may encounter clients who might want to know if they can practice intermittent fasting, right? So all this fasting here is restricting eating, yeah, on certain times of the day, and also people who are living with diabetes, yeah, whether they are on insulin or without insulin, Yeah, they should be monitored during the fasting period. They should be given some education if they want to fast. Yeah, what you should monitor and what are the plans. Yeah, and for Muslims, yeah, Ramadan fasting will last for a month. Yeah, where the Muslims will abstain from any food or drink, yeah, required from dawn to dusk, right? So individuals who are living with diabetes, who fast, yeah, they are exposed to increased risk of dehydration, hypoglycemia, yeah, sometimes hyperglycemia and ketoacidosis. Yeah, so a pre-fasting assessment, yeah, is very important. Before the patients is allowed to fast, they should consult their healthcare provider, and they can do a pre-fasting risk assessment to know, to assess the level of safety if they want to fast. Okay, so some of these questionnaires or risk assessment, yeah, they are available, yeah, with the ADA, so you can also obtain a copy, yeah, or after this, I'll send you the slides and also the recommendations by ADA for 2026. Yeah, the healthcare professionals should always ask their patients about their whether they are planning to fast. Yeah, and what are the risks? Educate them. If there are some dangers showing signs of hypoglycemia, what should they do? Yeah, to have a fast intake. They may have to break their fast. Yeah, in order not to make the condition worse. All right. So here, yeah, you can see that for religious fasting, yeah, 5.32, the recommendation, yeah, use the IDA along with the comprehensive pre-fasting risk assessment risk score tool, yeah, to assess the risk for safety of religious fasting, yeah, and assess and optimize treatment plan, dose and timing for people with diabetes, yeah, in advance of the religious fasting to reduce their risk of hypoglycemia, dehydration, hyperglycemia, and or ketoacidosis. Yeah, which means, yeah, they should consult their healthcare professional if they are planning to fast. And some adjustments to their treatment plan, insulin dose, yeah, will have to be optimized, yeah, for their fasting. Okay, so what about physical activity as a part of lifestyle management? Yeah, physical activity here includes all the movement that increase energy use. Yeah, and exercise would be a more specific form of physical activity that is structured, yeah, or designed to improve fitness. So there are a lot of studies, yeah, proving both physical activity and exercise have demonstrated various numerous benefits for people with diabetes or people at risk of diabetes. Yeah, and these are important as part of the diabetes management plan for your patients. Yeah, so the higher levels of total physical activity or leisure time physical activity or exercise, yeah, have been proven to be associated with lower risk of mortality. Yeah, lower risk of cardiovascular diseases in people with diabetes. Yeah, and exercise will help prevent the complications of type 2 diabetes and reduce the A1C, yeah, of individuals living with diabetes, right? So there are a lot of studies on the benefits, yeah, long-term benefits, even walking, yeah, a 6-minute walking distance, yeah, will suggest that the long-term benefits of regular physical activity engagements for these patients with favorable effects on the blood glucose levels, weight loss, yeah, body composition levels, yeah, improving their mobility and social and physical function in people with diabetes. So we will have some discussion now on the types, benefits, and what are the precautions and contraindications of physical activity and exercise, yeah, for weight management on for type 2 diabetes. Yeah, precautions, yeah, what you need to be careful, what you need to consider before advising your patient, and what are the absolute no-no, right? The contraindications of prescribing some form of encouraging your patients to be more physically active. Yeah, so for weight management, what will we look at? What is the physical activity focus? So the precautions that the dietitians, yeah, or exercise physiologists have to take, yeah, is to assess the assessment before they start a an exercise program. If the patient has become sedentary over a long time, we usually do not advise that they start an intensive exercise program. Yeah, you can start with lower intensity and lower frequency. And if they can cope, they can increase. Yeah, we'll talk about this more in the next few slides. Yeah, and this is based on the American College of Sports Medicine. Yeah, it's a guide for fitness and health. Yeah, for different disease conditions. If you are interested in physical activity prescription, yeah, the ACSM actually has a lot of management on how you can prescribe physical activity for different conditions. Yeah, to manage weight, to manage diabetes, hypertension, heart disease. Yeah, if you are dealing with patients with cancer, on cancer treatment, yeah, on arthritic treatment, yeah, they have arthritis. There are a lot of recommendations, and I would advise you to look at the American College of Sports Medicine prescription for exercise. Yeah, so back to weight management, yeah, for your patients with pre-diabetes or with diabetes. Yeah, we will aim to have some weight loss. Yeah, and the physician or the healthcare professional would have to be approached for a risk assessment. Yeah, do you feel tired upon doing some exercise, right? Do you feel shortness of breath? So there are some health risk assessment form, very simple ones that are available. Yeah. And for weight management, what are the prescription for aerobic exercise? Yeah, it depends on the goal, right? Let's look at the first row here. Yeah, if the goal is to prevent weight gain over long term, yeah, they can engage in moderate intensity physical activity, yeah, about 150 to 250 minutes per week, yeah, combined in a week. Yeah, this include exercising at moderate intensity, yeah, slow jogging, yeah, or brisk walking 30 to 50 minutes, 5 days a week. Of course, yeah, prevention of weight gain, yeah, can happen only if the same amount of energy consumed is the same as the energy that is expended while doing the physical activity. This is for prevention of weight gain. However, let's look at this goal to lose weight. Remember that a dose-response relationship exists, yeah, between the quantity of exercise and the amount of weight loss that is shown in your patient. Yeah, in other words, the higher the quantity of exercise and the higher the intensity, the greater the weight loss. But remember, yeah, if your patient have been sedentary most of their time, yeah, start very slow. Yeah, and there are additional benefits if the patient is able to do physical activity, yeah, at about 225 to 420 minutes per week, yeah, which is equivalent to at least 45 minutes of moderate intensity physical activity 5 days in a week. Yeah, this would give additional benefits. And weight loss will require a state of negative energy balance, and your diet must provide fewer calories, yeah, than one is expending. So you need to, if you need to lose weight, you need both. Yeah, you control your diet and you also do physical activity. Yeah, and the rate of weight loss can be enhanced by combining physical activity with food restriction. So after weight loss, what do they need to do to maintain the body weight? Yeah, to prevent the weight from fluctuating, yeah, the physical activity must be sustainable. Yeah, you must do something that the patient likes to do. Yeah, it can be accomplished by walking 60 minutes a day at a brisk pace to achieve moderate intensity physical activity, and they must maintain neutral energy balance, yeah, by eating only as many calories as they expend. So what are the resistance training prescription? Yeah. Besides aerobic training, we also recommend some bodyweight training or resistance training and also flexibility training. Yeah, for people with diabetes to lose weight, right? You need to also have resistance training, which should not be ignored. Yeah, because resistance training, yeah, will promote skeletal muscle growth. Yeah, which will contribute to increase resting metabolism. Right? So as caloric restriction and weight loss, yeah, sometimes lead to loss of skeletal muscle, you need resistance training to minimize muscle loss. Yeah, you can advise 2 to 3 days resistance training per week, right? And then there's also flexibility training. Yeah, this is more for daily functioning than for weight management. Yeah, but it is good that if your patient can do flexibility training 2 to 3 days per week, yeah, do some stretches. Yeah, this will increase their daily functioning, especially those of older age, right? Older adults living with diabetes or have pre-diabetes, right? So what are the key learning points here for weight management? Yeah, the key concept, energy balance. Yeah, food intake must be tailored to energy expenditure to achieve weight loss goals. And the best strategy for successful long-term weight management would be both food portion control and regular physical activity. So moving on to the topic of the day, which is physical activity for diabetes patients. Yeah, the patient should be encouraged to choose an activity that he or she is likely to maintain, rather than something that they don't enjoy. So walking, yeah, is very accessible. Yeah, it's free. Yeah, is accessible to most patients in terms of time and also for financial expenditure. Doesn't incur a lot of cost. Yeah, tell them they can go walking around the neighborhood, right? Or they can go to a nearby park, yeah, for a walk. So again, a physical activity and diet, lifestyle factors, you know that, yeah, and exercise improve blood glucose, and exercise need to be continued to be effective, because once you have stopped, the benefits related to the control of blood glucose will be lost within several days, right? So it's important to improve A1C levels in your body, and weight loss would decrease abdominal fat, which can help to reduce insulin resistance and improve glucose absorption in the body, right? Okay, remember some precautions before exercise. Yeah, anyone with diabetes, living with diabetes, should be carefully evaluated before starting an exercise program. Yeah, so as they, if they are interested in increasing their exercise intensity, right, or frequency, or start an exercise program, yeah, tell them to speak to their physicians, right? Those with pre-existing microvascular disease or macrovascular disease, they should not start a vigorous exercise without being seen by a healthcare professional, right? If they fall into any of the categories here, they should do a cardiac stress test before exercising. If they are older, yeah, and they have been sedentary most of their life, right? They have been sedentary and living with diabetes for more than 10 years. Yeah, they have type 2 diabetes for more than 10 years. Yeah, or if they know they have a major risk factor for heart disease, right? Obese, smoking, high cholesterol, yeah, a stress test with the healthcare professional is advised. Or with some normal exercise, with some light exercise, there is chest pain and discomfort, yeah, the exercise should be stopped immediately and be evaluated. Okay, if the patient is living with microvascular or macrovascular complications, yeah, it can be quite complicated here. If there is only mild retinopathy, yeah, the blood vessels in the eye are affected, they do not need major change. But if they have this moderate non-proliferative diabetic nephropathy, yeah, which is quite chronic already, yeah, they should avoid exercise that affect their blood pressure. For example, heavy resistance training, yeah, weightlifting of very heavy dumbbells should be avoided. Yeah, they should avoid contact sports, yeah, like rugby, for example, yeah, sports that require heavy lifting, which can affect their blood pressure, yeah, or worsen their retinopathy, right? They can focus instead on some low impact cardiorespiratory exercises like walking, or swimming. They can do that, or cycling, right? If they have peripheral neuropathy, yeah, in their limbs, okay, you should know that fall, yeah, joint and soft tissue injuries can be quite common among the patients. So it's very important, if they go for walks, yeah, they go for cycling, they wear proper shoes and socks, yeah, should be used to protect the feet. Yeah, they should inspect their feet before and after going for exercise. If they have blisters or ulcers, should be treated immediately. Yeah, and low impact activities that are easier for the joints, yeah, like swimming, yeah, you use a stationary bicycle, yeah, can be better to limit the complications. If the patient already has kidney damage, yeah, what do you do, right? Strenuous activity can further damage the kidney function. So if the patient has nephropathy, yeah, it should be evaluated before they start the exercise program by the medical doctors, right? So next, exercise have effect on the blood glucose. Yeah, sometimes hypoglycemia can happen, and you can see the symptoms of hypoglycemia. Shakiness, they feel weak, right? Abnormal sweating, okay, nervousness, anxiety, headache, tingling. Yeah, and the worst case would be a seizure and also go into a coma. So we do not want the exercise hypoglycemia to happen. So the key here is to check on the blood glucose on a regular basis to manage diabetes and to ensure safety while exercising, right? If there are symptoms, yeah, treat the hypoglycemia, right? They should always bring some source of glucose with them. Yeah, if they are feeling some symptoms of hypoglycemia, they should consume the glucose containing product. Yeah, juice, glucose tablets, or some candies. Yeah, if they go for exercise, try not to go alone. Go in a group and tell them, tell your friends that they have risk of hypoglycemia or even hyperglycemia. Yeah, so that if they have some medical emergency, yeah, the friends can call for emergency assistance. Yeah, of course, they should be consistent with their carbohydrate intake, yeah, their daily carbohydrate intake, yeah, with the role of dietitians to advise and maintain a regular time of the day for exercise. Okay, and then what about delayed onset glycemia? Yeah, this is a phenomenon that can happen 6 to 17 hours after exercise. Yeah, you can see that the blood glucose become very low. Yeah, and eating regularly and monitoring of blood glucose can delay this condition, right? And there is conditions called diabetic ketoacidosis here. Yeah, I would leave this part for students to do some self-reading, yeah, on diabetic ketoacidosis, yeah, which happen due to uncontrolled diabetes, right? And then there are some ketones accumulating in the blood, yeah, and if serious, yeah, this should be referred to a healthcare professional. Okay, so physical activity prescription for patients with diabetes. Yeah, we will prescribe aerobic and also resistance training and flexibility training. Yeah, so I will focus this on type 2 diabetes. Yeah, and if you look at the table here, these are the final targets. Yeah, not the initial levels. Yeah, if the patient has been sedentary, start very slow. Yeah, and the goal is to improve health outcome. Yeah, program, same like diet, exercise program should be tailored according to the patient's situation. Yeah, tell them, monitor them, look at their risk assessment, right? If you are to tell them to do normal aerobic activities, yeah, they can do this to improve their cardiovascular system. Yeah, if they are just starting to do exercise, begin slowly, begin gradually, as the body will need to adapt to the exercise and they should monitor how their blood glucose are affected. Right? Frequency of aerobic training, 3 to 7 days a week. Yeah, on a level of exertion, the intensity would be level 5 or 6 on the 10-point scale. So if you look here, yeah, on the right side of the chart here is the rating of perceived exertion. This is what we call a Borg scale of activity and exercise. Yeah, you can use it to understand how hard you are working during the exercise. If you are feeling breathlessness during the exercise or during the physical activity. Yeah, this is based on how much effort your breathing takes. Yeah, at rest. Yeah, and during activity. So at rest, you feel that you are okay. Yeah, but with activity, yeah, you feel that you are about to begin to feel breathless. Yeah, and this scale will give you a guidance on how you can exercise, how your patients can exercise at a safe level. Yeah, so for aerobic intensity, yeah, should be only at level 5 to 6 and not until, yeah, they're feeling that they're going to go out of breath, right, and about to pass out, right? Aerobic prescription, at least 150 minutes of moderate intensity per week. yeah, and it should involve the large muscle group. You go for brisk walking, biking, yeah, even water aerobics and aerobics, yeah, Zumba, right? And then resistance training, recommended 2 to 3 days a week, yeah, lower intensity, yeah, at level 4 to 6 of exertion scale, yeah, for each set of resistance training, like a weight exercise, 8 to 12 repetitions, yeah, that involve the major muscle groups. So resistance activity, yeah, are movements that you make, yeah, to improve skeletal muscle strength and size. Yeah, you can use free weight machines, yeah, use your own body weight, use resistance band, yeah, to target the major groups. Yeah, so for diabetic patient, resistance training, yeah, have been proved to improve glycemia, improve muscle strength, promote bone mineral density and cardiometabolic health. Yeah, and all these are associated to better insulin sensitivity and lower diabetes risk. Okay, so 2 to 3 days per week for resistance training. Flexibility, yeah, also 2 to 3 days per week. Yeah, this flexibility and balance activity, yeah, will help to reduce the risk of falls, especially in older adults. Yeah, they can participate 2 to 3 times a week. Yeah, and they can do other variety of activities for flexibility, yoga, yeah, Pilates, Tai Chi, right? If your patients is able to do that, yeah, it can significantly improve A1C, yeah, strength, flexibility, and gait, especially in older adults. So the key learning points, individualize the strategy for exercise. Yeah, it should improve health outcomes and blood glucose control. Yeah, and the healthcare provider and diabetes educator can make adjustments in the medication or insulin while one is starting to do more exercise. So again, the whole healthcare team, yeah, physicians, dietitian, healthcare provider, and diabetes educator, yeah, pharmacists can monitor the patient. Yeah, so from the ADA diabetes care management here on aerobic activities. Yeah, it is summarized in this. Yeah, but it's very important for you to know the sitting and breaking up prolonged sitting. Yeah, so advise your patient to limit sitting time. Yeah, break out prolonged sitting. Try to move every 30 minutes. Get up from the chair. Yeah, go for short walks. Yeah, with regular bouts of short walking and resistance exercise can improve glucose metabolism, right? Increasing steps, yeah, small increase of only 500 steps a day can reduce risk of cardiovascular related morbidity and mortality. So they can do walking, yeah, to improve their health outcomes. And then for sleep, yeah, they should aim for consistent uninterrupted sleeps, yeah, even on weekend. Yeah, have enough sleep and good quality sleep. Yeah, and then we have also covered the strengthening activities and aerobic activities. And for older adults, yeah, the physical function of the muscles is very important. Yeah, we should prevent obesity, sarcopenic obesity, yeah, which is quite common in adults with older adults and adults with diabetes. Yeah, the impact on physical activity, yeah, is concluded here. You can see that there are a lot of strong evidence, yeah, as indicated in the green arrows here. Yeah, the positive impact, strong evidence of positive impact, yeah, of activity and adequate sleep on glycemic control, yeah, as well as on other A1C, lipids, yeah, and quality of life in general. Okay, so to summarize, yeah, what are the nutrition behaviors that you can encourage in your patients? Yeah, start with vegetables. Yeah, especially non-starchy vegetables that are dark green, red, and orange color. Yeah, whether fresh or frozen, and low sodium canned options can be acceptable. Yeah, legumes, dried beans, pea, lentils, yeah, from tofu, from local tempeh, yeah, all these are can be encouraged. Fruits, yeah, should be whole fruit, fresh, yeah, frozen, yeah, with no added sugar can be acceptable fruit options. Yeah, food with at least 3 grams of fiber serving, yeah, are considered higher fiber choices. Go for whole grain food. yeah, if they are culturally appropriate, right? Do not force your patients to take oats if they are not used to. Yeah, you can introduce if they can accept this. Yeah, you can focus and try to give them some options. But when it's not culturally appropriate, focus more on the portion control. Tell them, okay, how you should stagger your carbohydrate intake, right? Water would be the primary beverage of choice. Yeah, do not order sweet tea, yeah, or other sweet options. Focus on plain water. Yeah. If they do not prefer plain water, they can take non-calorie alternatives. Yeah. They can add lemon, lime, yeah, berries or cucumbers into water. Right. Plant-based protein, legumes, yeah, can be encouraged, nuts and seeds. And meat, poultry should be from fresh options, yeah, and in the lean forms. Remove the skin, yeah, and avoid eating the internal organs of the animal, right? Heart healthy, wild caught fatty fish, yeah, including tuna, right, sardine and mackerel, yeah. All these, they are local species of mackerels and sardines, yeah, that can be easily available, yeah, in our Asian waters as well, yeah. Or they can take fresh, frozen or low sodium options, can all be acceptable. Yeah, they can use herbs, yeah, basil, mint, rosemary, yeah, and spices, yeah, like ginger, pepper to season the food instead of adding a lot of salt, or condiments like fish sauce. Yeah, incorporate onion, garlic, yeah, and all these other vegetables as a base while preparing homemade foods. Cook with vegetable oils. Yeah, plan eating out for the week. You can use a list to grocery shop. Yeah, do meal preps. Yeah, cook on the day when you are free. Yeah, if they have busy schedules, yeah, they can meal prep and then freeze and prepare ready to reheat homemade meals, yeah, waiting in the fridge or freezer. Yeah, that can be suitable for our case study, the second person, yeah, which is very busy. Yeah, they can include family or roommates in meal preparation. Yeah, share the responsibility of grocery shopping and cooking, yeah, and prepare meal in advance if possible. So looking at the different case studies here, yeah, the first executive here, which had rice 3 times daily, yeah, you can educate on portion redistribution, yeah, of the carbohydrate, yeah, and ask them to increase fiber intake, yeah, instead of strictly eliminating rice from the diet. Teach them carbohydrate counting or portion redistribution. Yeah, for the second case, yeah, you can teach them about glucose control, yeah, how to reduce sugar sweetened beverages, yeah, to reduce glucose in their beverages, plan for eating out healthily. And for the third case, yeah, teach them balanced glycemic control, yeah, how to slow down the nephropathy, yeah, and also to preserve muscle, yeah, because the patient have low appetite, yeah, and loss of muscle function and muscle mass can happen. So adequate protein must be endorsed for this patient, right? And with this, we have concluded on all the learning outcomes here, yeah, including behavioral strategies for managing type 2 DM from the diet and physical activity point of view, right? So I would like to acknowledge, yeah, my colleagues who are also experts in diabetes care, yeah, and I welcome you to send me emails. Yeah, you can follow me on LinkedIn if you want. Yeah, I may be sharing some information, yeah, latest information for you to practice as dietitians in the future. Yeah, you can send me an email as well, right, if you have questions. So I would end my sharing here. And if you have questions, and it's back to the moderator. Thank you so much for listening. I will end the slideshow and go back to the Zoom.
Thank you, Dr. Lee, for the masterclass in MNT. That was a very comprehensive explanation. If I could summarize this lecture today, we are highlighted that medical nutrition therapy in type 2 diabetes goes beyond glycemic control, addressing cardiometabolic health, weight management, and long-term outcome. We also gained valuable insight into carbohydrate management and practical behavioral strategy for effective implementation. And overall, this reinforced the importance of individualized, evidence-based nutrition care in type 2 diabetes mellitus. And before we go to Q&A session, please allow me to introduce us again our speaker. So Dr. Lee is a senior lecturer at the Department of Nutrition and Dietetics at IMU University, Malaysia. Her influence in the field extends across borders as she is a prominent member of the Young Scientist Network Academy of Science Malaysia and holds certification with the International Society for the Advancement of Kinetopometry. Beyond her teaching, Dr. Lee is a prolific researcher. Her work has been published in high-impact journals such as the British Journal of Nutrition and the European Heart Journal. She has pioneered fascinating research into nutrigenetics, specifically looking at how our genes interact with our diet to influence body weight and blood pressure. Most recently, she has been exploring innovative treatments such as the glycemic effect of the mulberry leaf extract. Now, we have learned more about our speaker background and achievement. We will process to the Q&A session, but because the limited time, we divided this Q&A session to two parts. Each session have a three questions. Please feel free to raise your hand or write your question in the chat box. I see Tiara Sita raise her hand. You can ask your question, Tiara. The time is yours.
Good morning, Dr. Lee. My name is Tiara and I am first grade. I want to ask about how to regulate the diet of diabetes during fasting. Thank you.
All right, sorry, I was muted. Yeah, so during the Ramadan fasting on how they can regulate their blood glucose, right? So it's very important that you should do some regular blood glucose monitoring. Yeah, if they are unable to do some blood glucose monitoring, right? You can ask them, what are the options of carbohydrate intake, right? Options intake during their sahur, right? They must have some vegetables, also protein intake and adequate carbohydrate intake that can promote satiety before they break their fast. And throughout, you should also warn them what are the signs of hypoglycemia, right? And if they are unable to manage, right, they should have options to break their fast, right? The third one would be during of their fast. Usually you take kurma, right? Dates. Yeah, you should advise them on how many dates that they can consume to regulate their blood glucose so that it doesn't shoot up, and how they should have some small snack before they go for prayer, and then after the prayer they can take their food intake. And also after Tarawih, they can also take more meals, yeah, and also have adequate water consumption to prevent dehydration. Thanks, Tiara, for your question. Very good question. Yeah, especially now that it's the Ramadan fasting month.
Okay, thank you very much, ma'am.
Okay, the second question. I see Anang has their hand raised. Please unmute yourself and go ahead with your question, Anang. Anang, please unmute yourself and go ahead with your question.
Okay, thank you, moderator. I would like to ask
Sorry, Anang, your microphone.
Okay, thank you, moderator. I would like to ask the latest International Diabetes Federation or IDF Diabetes Atlas 2025 reports that 1 in 9 of the adult population aged 20 to 79 lives with diabetes. What do you think is the reason why the number of diabetes patients continues to increase every year, even though information about healthy lifestyles has been socialized many times? Thank you.
Okay. Thank you, Anang, for your very good question here. Yeah, there are a lot of public health dissemination about prevention of diabetes, but we still keep seeing that the numbers are increasing. Okay, firstly, it can be due to the aging population. As the age increase, yeah, the metabolism and the endocrine system weakens, yeah, and with the number of older adults, yeah, that are getting older, you can see that they are more susceptible to diabetes. That is on the physiological or the normal human aging process. You can also see, yeah, next would be the changes in the nutrition transition, the environment, okay, the food environment, right? Maybe you can imagine you are young, all of you are very young, yeah, but if you look at my age, maybe, right? When I was younger, yeah, I don't see a lot of eateries that have all these very energy dense foods, sugar sweetened beverage. You don't see that. I don't want to name brands, yeah, but these brands are popping up. Really, you see them all over the place. Yeah, not fast foods and then sugar sweetened beverage, very energy dense foods. They are popping up near you and they are sold at very affordable prices. Yeah, so we should also know what are the environment of your patients, of the population, that are causing all these non-communicable diseases, increases the risk of obesity in your patients. Yeah, and then the third fact may be due to reduced sedentary lifestyle, reduced physical activity or increased sedentary lifestyle. Yeah, we are less physically active compared to many years before. Yeah, we used to be very active. Yeah, you travel from one places to another, but now with automobiles, with motorcycles, yeah, with cars, and then with a lot of appliances that you are focused on your screen, you reduce physical activity time, right? Students in school, they may used to play outdoors more. Yeah, but now with gadgets, you're looking at your tabs, at your phones, at your iPads, playing games more. Yeah, and this will increase the risk of diseases due to less movement. So diet, activity, yeah, and all this is difficult to make behavioral changes sometimes, especially when you are exposed to a lot of accessible ultra processed food that you can just grab and go, right? So all this might have contribute to the high levels of increasing levels and prevalence of diabetes and NCDs. I hope I've answered your question, Anna.
Thank you so much, Dr. Lee. Yeah. Huh? Yeah, thank you so much for the answer, Dr. Lee.
Thank you. We will now take a next question. For Yesi Putri, please unmute yourself and go ahead.
Hello, Dr. Lee. Allow me introduce myself. My name is Yesi Putri Anola. I'm a second year student. My question is very simple. I just want to ask, how medical nutrition therapy is currently carried out in public healthcare facilities across Malaysia? Is there a standard guideline used for dietary counseling? And in your experience, how consistent it is implementation within urban and rural healthcare setting? Thank you.
Okay. Okay. Thank you very much, Putri, yeah, for your question on MNT. right? So in the health clinics, we do have dietitians, and in Malaysia, yeah, dietitians are trained to provide nutrition counseling, medical nutrition therapy for the patients. So in rural areas, we have health clinics, which the patients are referred to. And for the older adults, it's actually quite affordable for the older adults to get treatment, yeah, in health clinics and to be referred to a dietitian by the healthcare professionals, by the doctors. So if they see, remember my presentation with an arrow. If the patient is already at pre-diabetes before starting medication, yeah, the patient would be referred to a dietitian. Yeah, would be referred to a dietitian by the doctors to make lifestyle changes. So if the lifestyle change work, they may not be prescribed with medication in their next visit. They will be monitored, right? If the lifestyle medication did not work after a certain period of time, maybe 6 months to 1 year, then the medication will be prescribed by the doctor. So in rural and urban, they have access to dietitians. And at the time being, the number of dietitians serving the number of patients that are very high is still inadequate, and there is a need for dietitians to come into place for MNT delivery.
Thank you very much for your time and for your addressing my question. I totally appreciate your valuable insight and clarification, Dr. Lee.
Thank you, Putri.
Okay, for the second session question, to Dina, please go ahead.
Good morning, Dr. Lee. My name is Dina and I'm in first grade. I would like to ask, how do you usually tailor a diet plan for diabetes patients who also have other conditions such as hypertension or obesity? Thank you.
Okay. Thank you so much, Dina, for your question. Yeah, this is where the ADIME or ADIME for nutrition care process will come in, right? The A, assessment, and then there's the diagnosis, intervention, and monitoring and evaluation. So during the assessment, yeah, we will try to identify what are the dietary or anthropometry measurements, body composition measurements, a very thorough assessment, yeah, of their dietary history and even their food environment, even their physical activity levels are being assessed. So with this assessment, we try to iron out which is their main nutrition problem, or they may have 2 or 3 nutrition problems, yeah, related to certain conditions, yeah, how you write your nutrition diagnosis, yeah, as evidenced by, okay, what are their HbA1c, what are their dietary intake. So we try to identify which are the main problems first to be addressed, right? At the same time, you might also, for example, I'll give you one very simple example. Excessive calorie intake related to, okay, you have all the different etiology and signs and symptoms. Yeah, you may want to highlight the blood glucose control and also the obesity first, and then the hypertension might come in second as a second nutrition diagnosis. So you also educate on certain items, yeah, depending on your patient. If your patient can get a lot of education at one sitting, then you can give your diet intervention. But sometimes, yeah, it takes a long time to change. So follow up with them. Give them another appointment for 6 months after, right? Then you teach them, okay, this is how you should control your sodium levels. What are the high sodium food checklists that the patient takes? So assessment, okay, give the diagnosis, give the intervention, and it's important to monitor and evaluate so that the next dietitian who was seeing the patient, yeah, can know what have already been educated and how they have been coping with your strategies and how they can improve after that. Yeah, okay, Dina?
Thank you so much, Doctor.
Thank you.
Okay. Now we will proceed to the next participant. Jonathan, please unmute yourself and share your question. Jonathan, please unmute your.
Okay. Good afternoon, everyone, and good afternoon, Dr. Lee. My name is Jonathan
Mm.
Valerio Legra. As a first year student from Applied Nutrition and Dietetics program, Dr. Lee, I want to share something that I actually see happening around me, even in Patian already know that even in my own family, a lot of type of 2 diabetes patient already know that food are good or bad for them. They have been told by the doctors and nutritionists many times, but somehow their blood sugar is still not well controlled. And when we ask them why, they usually say, "I have been eating like this my whole life. It's already hard to change." So this makes me wonder, literally, in medical nutrition therapy, how important is it to consider a patient cultural background and eating habit when making a diet plan? And what is the best approach for us as a nutrition student and future professional to help patient not just understand what to eat, but actually make it happen in their daily life? Thank you so much, Dr. Lee. I really look forward to hearing your answer.
Okay, thank you so much, Jonathan, for your very good question. Yeah, it happens around us very frequently. Yeah, it happens to my own mother. Yeah, when she was diagnosed with pre-diabetes, yeah, she doesn't really take advice from me and has to be sent to another dietitian for consultation. Right? I also wonder, hey, why don't you get the input from me? You don't really listen to me. Yeah, but sometimes getting an external advice, yeah, might be useful. Yeah, and secondly, when I address your question, Jonathan, behavioral change will take a lot of time, and sometimes it's important to use the motivational interviewing method. Yeah, giving motivation, assess your patient. What is their drive to change? Right? What is valuable for them? Yeah, you need to know their social cultural background, get to know them more. Okay, what is important for them? Okay, maybe for a mother, it's important for her to watch her children grow up. Maybe for a grandmother or grandfather, they want to be healthy to look after their grandchildren. Yeah, then you emphasize that it's important for you to make the changes. Yeah, so you control your blood sugar level, tell them what are the complications if you don't take care of your own health, if you don't take care of your blood sugar, right? You might be having some ulcer, diabetic foot ulcer, you need to go for a surgery, right? For amputation, and you will have decreasing quality of life, and you can't spend some time with your grandchildren, with your family. You cannot travel, right? Or if your patient really wants to go on Hajj or on Umrah, right? So if they are motivated to do something, right, they should take care of their health, right? They should avoid complications. So use these motivational techniques, yeah, to encourage them to make the changes. So motivational interviewing techniques, yeah, knowing that, and some referral to psychology, yeah, psychologists may be needed to help them make the change. So healthcare team should come together to help the patient. Okay, Jonathan?
Thank you so much, Dr. Lee, for answering my question. It's very helpful.
Thank you for your question.
Okay, the last question from Aisha. This will be our final question due to time constraint. Aisha, please go ahead.
Good morning, everyone, and good morning, Dr. Lee. My name is Aisha Florentia. I'm a second grade associate degree nutrition student. My question is, how effective are Malaysia's public health strategies in preventing type 2 diabetes mellitus? Thank you.
Thank you, Aisha, for your question. Yeah, how effective it is. Um, there are a lot of ongoing strategies for prevention. Yeah, nutritionists, there are a lot of healthcare professionals who endorse, yeah, healthy eating methods, but due to some reasons, yeah, environment reasons, aging population, you still see that the numbers are increasing, right? There are some effective strategies out there, but there are also some ineffective strategies. And the Ministry of Health, is keep on going to improve on their strategies for public health, for prevention of diabetes. It's an ongoing and it's a war to fight. It will take a lot of time, but public health strategies shouldn't be slowed down or stopped, for diabetes prevention. I hope in Indonesia that is the case as well, Aisha, what do you see? Do you see a trend in improving public health education? Yeah, no worries, Aisha. Strategies, they are ongoing, a lot of ongoing strategies. Some effective, some are ineffective. That's my answer to your question. Healthy eating
Thank
strategies
you
is
for
out
your
there.
insightful lecture, Dr. Lee.
Thank you for your question.
Okay, we apologize. Not all questions could be addressed to time constraint. Once again, thank you, Dr. Lee, and thank you everyone for your participation. Unfortunately, we have reached the end of our session. Dr. Lee, thank you for challenging our perspective and providing us with such a rich, evidence-based deep dive into diabetes management. To our students, I hope this session has inspired you to look beyond the textbook and see the impact that the dedicated research has on real-world clinical outcomes. Thank you all for joining. Have a wonderful day. And now I return it back to the MCU.
Thank you, Salza.
Okay, thank you, Salza. Now we will have a virtual certificate handover. Dr. Lee Yi, before we wrap up today's session, I want to take a moment on behalf of Poltekkes Kemenkes Bengkulu to formally thank you. Your insights on diabetes were not only enlightening but also incredibly timely for our group. I would like to invite Head of Nutrition Department, Mr. Anang Wahyudi, to deliver the certificate.
Okay. Okay. Hello, Dr. Yi or Dr. Lee, I call you.
Yes, Dr. Anang, thank you.
Okay. Dr. Lee, thanks for sharing your time and knowledge with us. Thanks providing alignment in guest lecturer today. Please accept the certificate of appreciation from us, and we hope that will serve the beginning cooperation between Poltekkes Kemenkes Bengkulu and IMU University. Thanks a lot, Dr. Lee.
Thank you so much for inviting me. And thank you to the students for their attention, listening to the lecture that can be quite lengthy, but I hope it can be beneficial for their future practice and for their studies. And thank you, Dr. Anang, and the organizers as well.
Okay, thank you. And second, that a more intensive collaboration can be established about between IMU University and Poltekkes Bengkulu. Thank you. Thank you very much, Dr. Lee.
Thank you.
Okay, thank you, Dr. Lee and Mr. Anang. Before we end this session, we will have photo session. Start from slide 1. Please open to your camera. Slide 2. Slide 3. Four.
Nah, sudah itu. Yang sudah keluar gitu nih. Foto tuh.
5. 6.
Ya lilinya tidak apa foto, no.
7. 8. 9. 10. Okay. Ladies and gentlemen, we have come to the end of this session. We would like to thank you, our speaker, Dr. Li Yi, for sharing such a valuable knowledge today. Let's close this lecture by reciting Hamdalah together. Alhamdulillah. Thank you for your active participants. Have a wonderful day, and thank you for Dr. Li Yi.
Thank you. Bye-bye.
Bye-bye.
Thank you. Bye-bye.
See you.
Bye-bye.
Bye-bye. Bye.
Absensinya ya, Nak. Nanti di-share ya, diletakkan. Terima kasih, izin lip ya.
Sama-sama, Bunda. Terima kasih.